Hi students, welcome to another session of Internal Medicine Part 2 from Medicoz Community. So I wish you all the best for the upcoming NEET PG 2023. And I know you're all tensed and you're going through your notes and last minute revision, but I want you to step back and take a look at these very important MCQs that we have compiled together from Medicoz Community. So without further ado, let's start with this session. Could any of you who are attending the lecture give me a thumbs up in the chat box so that I can know that I'm audible and visible to you people? Okay, okay. So let's start with today's session. So first question of today's session, that is continuing, is question number 13. A 16-year-old boy presents to clinic with an acute respiratory tract infection. He has a history of asthma associated with recurrent respiratory infections. All right. And he also suffers from sinusitis. Genetic testing in childhood has revealed CFTR mutations. Which of the following is likely to be decreased in this patient? Please pay attention to all the key words that I have underlined. One is the recurrent respiratory infections. The second is CFTR mutation. And they're asking what is decreased. Okay. So I'll give you 2 minutes to, ponder over the question and put your answers in the chat box. What do you think is the likely answer in this question? Is it A, sweat chloride, B, immunoreactive trypsinogen levels, C, serum bicarbonate levels, or D, is it sperm count? So what do you think is the answer for this question? Okay. First of all, when you approach such clinical questions which ask you seemingly confusing concepts, you're first supposed to find out what is this disease. So students, what disease are they talking about? They are talking about something which has a CFTR mutation, which is the famous cystic fibrosis. All right. So cystic fibrosis. So cystic fibrosis, correct. Aarti Das has told me that the answer is D. All right. So very good, Aarti. So we'll see now. Cystic fibrosis is because of a gene mutation called CFTR on which chromosome? On chromosome 7. Okay. And what are the clinical features of cystic fibrosis? Chronic sinusitis, bronchiectasis, obstructive cirrhosis, pancreatic insufficiency, productive cough, constipation, meconium ileus, and infertility. Okay. So remember all of these because in this patient, the clinical scenario that they have given you is recurrent respiratory infections. All right. So according to this, how do you approach such a child or such a patient? If the patient has clinical symptoms, positive family history, or there is a positive newborn screening. Now, what is the screening test used? The screening test used in newborns is your immunoreactive trypsinogen. Immunoreactive trypsinogen. Please remember this. All right. So, if any one of them are positive, then we go ahead with a sweat test. In the sweat test, we measure chloride levels. If the chloride levels are more than 60 millimoles per liter, we do a repeat measurement. If the repeat one is also chloride more than 60 millimoles per liter, the diagnosis is confirmed. What is the other way we can confirm cystic fibrosis? We do a CFTR mutation genotyping. So in this, if there are 2 genes which is mutated, then again it is confirmed. If there is only 1 gene mutation, then we go ahead with a nasal potential measurement. Okay. The potential difference in the nasal cavity is measured, okay, by the biopsy of rectal mucosa. So if only one CFTR gene is mutated, we go ahead with nasal potential difference. All right. So this is something, there are multiple points at which you can have MCQs. Okay. So you need to remember this. So going back to our question, sweat chloride is elevated. Why? Because there is defective chloride transport. Second is immunoreactive trypsinogen level is increased. Okay. It is because of exocrine pancreatic insufficiency. Now, this, like I told you, is newborn screening test. All right. Okay. Next is serum carbonate, bicarbonate levels. This is also increased. Why? Because there is excessive loss of chloride causing hypochloremic alkalosis. Option D, sperm count, is the only one which is decreased or absent. Why? Because there is absence of vas difference and defective sperm transport. Okay. In short, you must remember that cystic fibrosis is a ciliary dysmotility problem. That is, the cilia is no longer motile. That is why the patient has recurrent respiratory infections, azoospermia, bronchiectasis, liver cirrhosis, and multiple such abnormalities. Okay, chromosome 7 and CFTR mutations, sweat chloride test, CFTR mutations, and nasal potential difference. So these are some important keywords you should remember from cystic fibrosis for your upcoming exam. All right. So let's go ahead with the next question. So a 62-year-old female presents with severe right-sided throbbing headache. She also gives history of pain and stiffness of the shoulders and hips. Her ESR is 82. So it's an aged patient with an ESR of 82 with a throbbing headache. All right. So the question is, what is the next best step? Okay, please pay attention here. They're not asking management, they're not asking diagnosis, they're asking the next best step. So what do you think is the answer? Is it A, perform temporal artery biopsy? Is it B, obtain a non-contrast CT head? Or is it C, start steroids? Or is it D, start beta blockers? So what do you think is the answer here, my dear students? Can you take a guess or probably think that this is probably the answer you would go for if this is repeated in day after's exam? Good, I am getting good answers. Okay. So Jagan says it's option C. All right. So good, Jagan, good attempt. So we're going ahead. We'll see why Jagan is right. All right. So what is the diagnosis of this patient? This given clinical scenario suggestive of polymyalgia rheumatica. With raised ESR, it points towards what? GCA, giant cell arteritis. It is a large vessel vasculitis. All right. So the next best step is to start steroids. See, initiation of steroids helps in reducing symptoms and preventing visual loss. Temporal artery biopsy can be done after starting steroids also, all right? Because it remains positive for a month even after the initiation of steroids. Suppose you say, no, I want to diagnose the patient, I'll go ahead, confirm with a temporal artery biopsy. You risk making the patient blind forever. Why? Because there is ophthalmic artery involvement. Okay. So you can start steroids and then go ahead with diagnosing or making a confirmatory diagnosis of this patient. But the next best step is always starting steroids in a case of GCA. So what were the key points? One is the patient's age will always be more than 50. The ESR will be raised and they will have myalgia. Okay. Okay. This is why polymyalgia rheumatica is associated with GCA. Now, if they ask you treatment options in GCA, you should also know. Always be prepared for the next step. First line is glucocorticoids at high dose. Second line is methotrexate and IL-6 receptor inhibitor, that is tocilizumab. Third line is tocilizumab, and some people also use abatacept. Fourth line, which is under research, is ustekinumab and abatacept and other anti-IL-6. Fifth line is your experimental JAK-STAT inhibitors and interferon gamma inhibitors. All right. So we are trying to cover as many concepts as possible under one topic. So I want you to be thorough with GCA, its management, and what is the line of emergency management in cases of GCA. All right. Okay. So students, pay attention here. This is a clinical scenario where a patient presented with breathlessness on exertion and chest pain. Auscultation revealed what? An ESM. What is ESM? Ejection systolic murmur. It is heard at the base of the heart. Echocardiography revealed reduced LVEF, that is left ventricular ejection fraction, and left ventricular hypertrophy. All of the following features signify severe form of the disease except palpable carotid thrill, pulsus parvis et tardis, wide splitting of S2, presence of S3, S4 heart sounds. So first you please recognize which heart disease are they talking of. Which valve are they talking of? Is it the aortic valve, the mitral valve? Can any of them guess what is the answer to this question in the chat box? I'll wait for you. Okay. So ejection systolic murmur is seen in which disease? Ejection systolic murmur is seen in aortic stenosis and pulmonary stenosis. In aortic stenosis, there are some signs and symptoms which can tell you whether the disease is progressing, whether it is becoming severe. Okay, so what are the signs of a severe aortic stenosis? That is the question. So you need to know what are the indicators for severe aortic stenosis. Okay, so exertional angina, syncope or pre-syncope, dyspnea, low volume, a slow rising pulse, the famous pulsus parvis et tardis, the narrow pulse pressure. What do they mean? So they're saying that the BP will be 120 by 98. Okay, so the pulse pressure is becoming narrow, or it will be 110 by 90. So the very narrow pulse pressure. Okay, less than 20 will be the difference between your systolic and your diastolic. So that is why they're trying to tell you that the disease is progressing. All right. Apart from narrow pulse pressure, what else? You will also have a prominent A in JVP. You will have a heaving apex, a LVS4, delayed A2, a long mid-systolic murmur with late peaking, LV strain pattern in ECG. Why do we have? Because of LV hypertrophy. All right. Because of LV hypertrophy, we have a LV strain pattern in ECG. If you're not aware of these signs, please make a note of it. All right. So you need to learn as much as possible before you go inside that exam hall of yours day after. Okay. So let's see here what happens to the S2 in aortic stenosis. Okay. So if you can notice here, the S2 has two components, A2 and P2. Okay. So normally the A2 occurs and then the P2 occurs. So this is the gap which is normally present. Okay. As aortic stenosis progresses, the gap reduces. Okay, because the LV takes more time to eject out the same amount of blood. Hence, the A2 becomes very close to the P2. As it progresses further, the S2 becomes a single sound. There is no A2P2. When it becomes severe, what happens? The P2 arrives first and then the A2 arrives. This is known as paradoxical splitting. Paradoxical splitting. Okay. So please remember what are the causes of paradoxical splitting, my dear students? One is severe AS and it is also seen in left bundle branch block. Okay. So I want you to remember signs of severe aortic stenosis and I want you to remember paradoxical splitting of S2. Okay. So in this question, what will be the answer? The answer will be wide splitting of S2 is not seen in the severe form of aortic stenosis. Instead, we see paradoxical splitting of S2. Alright, am I clear? Fine. Okay. So going ahead, good, good. You know, you should keep learning new things even before the exam so you remain a little bit novice and not too overconfident. So let's start with our next question. A 3-month-old baby presented with history of constipation, lethargy, and poor activities. So clinical examination revealed jaundice, hypotonia, and there was no palpable goiter. Laboratory testing revealed low T4, elevated TSH. Which of the following statement is not true about this condition? I think it's a no-brainer. I think all of you would have guessed that this is a case of congenital hypothyroidism. Okay, this is a no-brainer. So I expect all of you to know this. This is a case of congenital hypothyroidism. They are asking which of this statement is not true, which is false. They're asking you to recognize. Is it associated with macroglossia? Yes. High circulating T4 is required to normalize TSH. Obviously true. Most common cause of this condition is thyroid gland dysgenesis. Again true. The development abnormalities is twice more common in boys. This is the false statement. So you have to recognize this is your answer. Okay. It is twice more common in girls. Okay. This is what you have to remember. Let's have a look at congenital hypothyroidism in case it comes for your exam. Given clinical scenario is suggestive of congenital hypothyroidism. The most common cause of this condition is thyroid gland dysgenesis. 80 to 85% of all congenital hypothyroidism is because of dysgenesis. Remaining cases are due to defects in thyroid hormone synthesis and rarely due to TSH receptor antibodies. Early treatment with T4 results in normal IQ levels by preventing neurodevelopmental abnormalities. So what will the mother come and tell you? The mother will come and tell you, doctor, my baby is a very good baby. Why? Because he doesn't do, any naughty stuff. He doesn't move around much. He lies in one place. This signifies the baby is lethargic. Okay. बोलेगी कि बहुत अच्छा बच्चा है कोई शैतानी नहीं करता है. So that means you should recognize that this means the baby is a little lethargic. A prolonged sleeping time, not awakening for feed, slow feeding. So these will be your points in history. So on examination, please note coarse facial features, macroglossia, wide fontanelles, easily palpable sutures, umbilical hernia, prolonged jaundice and dry skin. So these are all clinical features that you have to look for in congenital hypothyroidism. Alright? Okay. Okay, students. So the 17th question for the day is, in which of the following situations is nerve biopsy not indicated in patients with chronic inflammatory demyelinating polyneuropathy? This is nothing but CIDP. Okay. So first option A is when there is no clinical or electrophysiological evidence of nerve functionality, when the diagnosis is not certain, when nerve conduction studies show axonal involvement, or is it when other causes of polyneuropathy can't be ruled out? Okay. So I want you to take a guess. Which do you think is the option? What is the, biopsy? When is it not indicated? I'll wait for some time so that you can put it in the chat box. Okay, some people are saying it is D, some are saying it is A, some are saying it is C. Okay. So let's make it very clear now. Okay. So nerve biopsy is not indicated if there is no clinical or electrophysiological evidence of nerve function in CIDP. Okay, it's confusing, I know. What do they mean by this? Clinically, when you examine the nerve, you realize that the nerve is completely not functioning. Electrodiagnostic, that is, you conduct a nerve conduction study, an EMG. Again, there is no activity in that particular nerve. That means this nerve has completely degenerated. All right. So if you biopsy this nerve also, you will not get any results. You will not be able to find out what is the underlying pathology because the nerve is completely degenerated. So there is no use of this biopsy then. Correct? So what are the indications for nerve biopsy you should know? One is, this is a CIDP, that is, it is a demyelinating polyneuropathy. So if the electrodiagnostic testing, that is your nerve conduction, shows axonal involvement in CIDP, immediately you should realize there might be some other culprit in this picture. It might not be a simple CIDP. Next, diagnosis of CIDP is not clear or uncertain. You are not sure whether this patient actually has CIDP. Third indication is other causes of neuropathy such as vasculitis, amyloidosis, hereditary neuropathy called Charcot-Marie-Tooth disease. All these you cannot exclude it. So you want to do a nerve biopsy and exclude these other causes. Treatment failure, that is, you start treating for CIDP with what? Steroids, plasmapheresis, IVIG, or if there is an atypical presentation of CIDP, then also you do a nerve biopsy. Right. So the answer here, my dear students, is A, when there is no clinical or electrophysiological evidence of nerve functionality. The nerve is completely degenerated, and if you take that biopsy of that particular nerve, it's not going to yield any result for you. All right. Okay. Okay. 18th question is, a 25-year-old woman goes to her family doctor as she is unable to fall asleep at night. She complains of tingling and crawling sensation over her legs at night. She also feels strong urge to move her legs, which relieves her symptoms for a while. Which of the following statements is false? Pay attention and read slowly. Regarding this condition, most common movement disorder in pregnancy associated with low serum ferritin. Option C, autosomal recessive inheritance. Option D, chronic kidney disease is not the most common cause. So which of these statements is false? Please identify, students, and write it in the chat box for me. This must be a very easy answer for you, all right? Okay. So let's see whether any of you can guess it. Okay, the given case scenario, clinical scenario, is suggestive of restless leg syndrome or Willis-Ekbom disease. Okay, it is autosomal dominant inheritance. Please remember, it is an autosomal dominant inheritance. So you have already got your answer here. The answer is option C, autosomal recessive inheritance. Okay. So RLS is a neurological sleep disorder that can be primary or secondary. The primary disease is the most common. Okay. Secondary RLS is associated with the following: iron deficiency anemia, that is low serum ferritin. Okay. Pregnancy. So it is the most common movement disorder during pregnancy. Diabetes mellitus, chronic kidney disease, multiple sclerosis, and Parkinson's disease. So these are the secondary causes of restless leg syndrome. But remember, primary is the most common. Okay, chalo. So this is a very, very simple, very easy question. Which of the following features is not expected to be seen in patients with right? Please read it. Right middle cerebral artery infarct. Okay. Is it A, dysarthria, B, hemiparesis, C, facial weakness, or D, aphasia? So any of you students who are online, please try to guess which of these is not expected. That is, it will not be seen in right-sided MCA infarct. Okay. Chalo. We'll try to, decipher this code. Okay. We'll try to understand what is the difference between a left MCA infarct and a right MCA infarct and what to expect. Okay. Yes, Ajay has answered it to be D. Very good, Ajay. So let's see what are the functional areas of the brain. Okay, functional areas of the brain, I don't want to complicate much. Just remember the frontal makes you a good, a sincere and intelligent student. So high intellect, self-control, inhibition, emotions is frontal. Your motor and speech are here in this blue area, your voluntary eye movement, and then you have your motor and speech production and skills development area. You have your memory in your temporal lobe part, and you have some sensations in this area, and your language comprehension. What do you mean by comprehension? That is your Wernicke's. Understanding what I am teaching you requires your Wernicke's area. All right. So why have I drawn this picture? So that you know this orange part is by the ACA. This green portion is by the MCA. So this is your PCA. So they are asking you if the right MCA is there, what is not there? Okay, to understand this, of course, Ajay is right. D, option D, aphasia is the answer. Aphasia is not a feature of right MCA infarct. Aphasia occurs when there is damage to dominant hemisphere, that is left hemisphere. That is the left MCA infarct. Okay. So how do you remember this? You should always remember the common findings first. So if there is an MCA infarct, whether it is right or left, there will be contralateral sensory loss, hemianesthesia. Clear? Then contralateral hemiplegia. That is a no-brainer. Then there is a gaze preference to the side of the lesion. This again happens irrespective of right or left. If there is a left MCA, then you have aphasia. It can be Broca's or Wernicke's or even global. If there is a right MCA syndrome, then it is anosognosia, constructional apraxia, and hemineglect. So if all these, not typical ones, like you find in your question clues such as the patient is unable to identify his own body part or neglects the site of paralysis. So these are some clues that you have to pick up to localize the lesion. If they say there is complete global aphasia, then immediately you should think of left hemisphere infarct. Okay, children? So fine. So with this, we have somehow started our discussion on stroke. We'll continue with our next question, which is also from CNS. Slightly difficult one, but please do attempt. A 25-year-old female experiences severe throbbing headache, lateralized to right side. It is accompanied with nausea, vomiting, and she often feels dizzy. She is diagnosed with severe migraine. Which among the following is the most efficacious triptans used to treat this condition? I think everybody would have guessed. Okay, even a first year MBBS student would have guessed what is this we are talking about. It is migraine. All right. So for the treatment of migraine, all of you know that we use triptans. But the question here is the next level. They are asking which among these is the most efficacious ones. All right. Most common one is of course the sumatriptan. But is it the most efficacious? Okay, take a guess. Let me know in the chat box what you think is the answer. Just take a guess. Okay, Praveen Kumar says that it is B, Rizatriptan. Very good. Can anybody else attempt? Okay. So Praveen is right. It is Rizatriptan. Okay. Option B, Rizatriptan is the answer. The most efficacious triptans for moderate to severe acute migraine are Rizatriptan and Elatriptan. Oral dosage forms of triptans are the most convenient to us. Anybody would like to take a tablet than an injection. But patients with migraine should not forget they have vomiting, nausea. So they are unable to take oral forms. Okay. Sometimes you might require nasal spray and injectables during the acute attack. Okay. So standard treatment comprises 6 mg of subcutaneous dose of sumatriptan. So all the triptans have similar pharmacological properties, but they vary slightly in terms of efficacy. So to take home message, just remember Brizatriptan and elatriptan are slightly better than the other triptans. All right? Okay. So this is a very interesting question. So you are given the task to investigate an outbreak of Legionella pneumonia in your hospital. Okay. Which of the following is least likely to have played a role in the transmission of this organism? Is it air coolers? Is it evaporative condensers, humidifiers, or they've specifically mentioned split ACs, okay, home split ACs. What do you think is least likely? Please guess in the chat box. Let me know what you think. Okay, chalo, we'll try to, solve this question. It's okay even if you don't know this. So the answer is option D, home split air conditioners. So why is it home split air conditioners? Because they do not use water to cool the air. For Legionella to thrive and survive and cause so many pneumonia in so many people, it requires water. If there is no water, they don't have place to thrive. They don't have means to survive. All right. So home split air conditioners are not a risk for transmission of Legionella. So the risk factors for transmission of Legionella are contamination of water supplies in large facilities such as hospitals, hotels, apartment buildings, okay? Contaminated water sources such as hot tubs, birthing pools, fountains, whirlpools, and water using machinery like cooling towers, evaporative condensers, and humidifiers. So anywhere there is some source of water, it will help Legionella to multiply and to disseminate and cause pneumonia. So if you remember students that Legionella pneumonia is a very atypical pneumonia. So what do I mean by atypical? So what is the difference between typical and atypical pneumonia? So let's just revise your basics before you go for the exam day after, alright? Okay. So typical pneumonia has a rapid onset while atypical is slow. What are the organisms? This is very important. Please remember the atypical ones so you can always rule it out in your question. Mycoplasma, Legionella, Chlamydia, some strep pneumonia can also cause. This was also a question where they asked which organism can cause both typical and atypical. So you should remember strep pneumonia in that. Alright. And of course, viral pneumonia comes under atypical pneumonia. So the clinical features of atypical pneumonia are very different from your typical pneumonia. So non-pulmonary features such as gradual onset of fever, dry cough, myalgia, arthralgia, headache, okay, vomiting, and they might even present with chest pain to you. But respiratory symptoms like cough, breathlessness will be less prominent. Okay, this is your take home. So even the WBC, if you see, they will be within normal limits or just slightly raised. Okay. And the chest X-ray will show a non-lobar infiltrates. This, of course, everybody knows. So what is this kind of pneumonia usually called with non-lobar infiltrates? So this patient will come to you walking into the OPD even if he has a severe pneumonia. So it was known as what? It is known as a walking pneumonia. So that's how I remember that the patient will walk even if he has a severe pneumonia. So in atypical pneumonia, they're also known as walking pneumonia, especially mycoplasma is specifically known to cause walking pneumonia. Right? Okay. Let's go to the next question. I want you to attempt this because this has been previously asked. It's okay even if you're wrong. Please attempt this question. A 45-year-old man presents with progressive fatigue and weight loss for 3 months. CBC shows pancytopenia. On peripheral smear, the following cells are seen, which also showed positive staining with TRAP. Okay. What is the drug of choice for this patient? That means you need to first diagnose what does he have. What does he have? And what is the drug of choice? Is it A, vemurafenib, pentostatin, interferon alpha, or cladribine? Okay. Can you please write it in the chat box? What do you think? Okay. Let's see. So the answer, we'll first diagnose what this condition is. Okay. So the given picture shows mononuclear cells with abundant blue-gray or granular cytoplasm with elongated hairy projections, which are TRAC positive. Okay. So this clinical scenario is suggestive of hairy cell leukemia. The drug of choice is cladribine. Okay. So the answer is cladribine. Hairy cell leukemia is responsive to chemotherapy with interferon alpha also, pendastatin and cladribine. However, cladribine is the preferred drug of choice due to complete remission in majority of patients. And we also have a higher rate of disease-free survival. So chemotherapy refractory patients have responded to vemurafenib. It's a BRAF inhibitor. Please note this down. This can be asked in your updates. They can give you a clinical scenario of hairy cell leukemia and say that this patient is chemotherapy refractory. Okay. In such patients, what is your choice? So that time you should remember vemurafenib. All right. Okay, students. Let's move on to our 23rd question. A 29-year-old man with 3-week history of fever is found to have multiple rubbery enlarged lymph nodes. A biopsy reveals abnormal cells with bilobed nuclei that are positive for CD15 and CD30. I think most of the students would have guessed by now that what they are talking of. Which of the following is associated with this man's condition? Okay. Is it Lambert-Eaton syndrome? Is it SIADH? Is it subacute cerebellar degeneration? Is it superficial migratory thrombophlebitis? So first thing is you need to diagnose what this man has. The moment you hear CD15-30 in your question, you have to think of only one thing, that is your Hodgkin's lymphoma. So they are asking you which is the paraneoplastic manifestation of Hodgkin's lymphoma. So is it Lambert-Eaton or is it SIADH? So the answer here is, can you guess it? Someone guessing? Very good. I think Dhruv Kumar has guessed it right. It is subacute cerebellar degeneration. Okay. So subacute cerebellar degeneration is the answer here. So let's revise what are the paraneoplastic manifestations of Hodgkin's lymphoma. Minimal change disease presenting as nephrotic syndrome, vanishing bile duct syndrome, cholangitis, and very specific alcohol-induced pain. That is, pain typically after intaking of alcohol. Small amounts of alcohol also is enough. The pain will localize to areas involved by Hodgkin's lymphoma. So you need to know the paraneoplastic syndromes with HL. Please remember these four. And of course, your subacute cerebellar degeneration, which is the answer to your previous question. So what about the other options? Where is SIADH seen? It is seen along with small cell lung carcinoma. Lambert-Eaton is also seen with small cell lung carcinoma. Migratory superficial thrombophlebitis. What is this? This is nothing but Trojer syndrome. Okay, Trojer syndrome is associated with adenocarcinoma of pancreas and lungs. Okay, so this is your bite of paraneoplastic syndrome for your upcoming exam. All right. So, quick, tell me, a 36-year-old who is chronic alcoholic presented with acute, dull, boring abdominal pain. He's also on treatment with ART, your antiretroviral therapy. His serum lipase is grossly elevated. I think you people know now why his abdomen is paining. So they are asking you, what is the most likely causative drug? कौन सा drug है जो culprit है? Which is the culprit here, which is causing this abdominal pain? So what is the abdominal pain? It is pancreatitis. Simple, because serum amylase is increased and his chronic alcoholic, the lipase is grossly elevated. Okay. So pancreatitis is the side effect of which of these drugs? Can you guess? Please tell me in the chat box. Okay. So let's see. See, ART is a very important topic for your exam, and please revise, keep revising ART. So, didenosine is the most likely causative drug. The clinical scenario is suggestive of pancreatitis, which is a dose-limiting side effect of didenosine. Okay, it occurs frequently in alcoholic patients and those with hypertriglyceridemia. So what about the other options? Remember, side effects of nevirapine is severe liver problems, skin rash, and skin reaction. What do you have to remember of emtricitabine? It is contraindicated in children and pregnancy. What do you have to remember about stavudin? Peripheral neuropathy. Please make a note of this. This has been previously asked in both INICET as well as your NEET PG. Please remember stavudin and didenosine. Okay? All right. Okay. The last question for today's case scenario of an HIV positive patient is upset because he has high viral load despite good compliance with ART. Okay? So the physician decides to start him on a parenteral drug. Which of the following drugs will be helpful for this patient? Is it A, emtricitabine? Is it B, elbitiravir? Is it C, enfuvirtide? Or is it D, efavirenz? So any of you can attempt to answer this last question for today's scenario. You have a patient, you have put him on ART. He comes back to you after 6 months and says, Doctor, the ART is not working. My viral load is still high. So what would you give him? That is the question. Okay, and especially it's a parenteral drug. So that is your biggest clue in this question. Okay, the answer here is enfuvirtide. Okay, so enfuvirtide is an antiretroviral drug administered parenterally, used only in the treatment of those who have evidence of HIV replication, high viral load despite ongoing antiretroviral therapy. Enfuvirtide prevents viral fusion. So it's an entry inhibitor because it prevents the fusion of virus into our normal cells. What does it bind to? This can also be a potential question in pharmacology, GP41 subunit. Okay. It is not active against HIV too. It is administered as a twice-a-day subcutaneous injection. If you don't remember all this, just remember enfuvirtide is parenteral. It is used for non-response to ART and it binds to GP41. This is all I want you to remember. Okay. Remember, small bites and sizes. You will not be able to cover every topic from top to bottom now. I want you to just concentrate on previous year questions, hide the MCQs that we are uploading in all the live sessions, and make small notes and keep revising these MCQs because all of these MCQs that we have chosen are previous year and high yield case scenarios, which is likely in this year's NEET PG 2023. All right. So your ART, this is what I know is the basis of all your questions. You have to remember that the entry inhibitors or fusion inhibitors are enfuvirtide, maraviroc. NRTIs are tenofovir, adifovir, zidovudin, and didenosine. Where did we see didenosine with? We saw it with pancreatitis. Okay, where did we see stavudin? We saw stavudin with peripheral neuropathy. NNRTIs, you have efavirenz, nevirapine, two important ones. Protease inhibitors are ritonavir, darunavir. Your integrase inhibitors are dolutegravir and raltegravir. Okay, students. So I'll wait for you for some time. If you have any doubts, whether it's academic, non-academic, you want any motivation, please let me know. If you're feeling anxious also in the chat box. All right. Okay, so I think with this, we'll come to the end of our high yield MCQ session for internal medicine. I want you to keep revising. Don't lose hope. You're just in the finish line. And even a simple 1 minute MCQ can also change a lot of marks and ranks in your upcoming exam. So that doesn't mean you need to be tensed and lose sleep over it. Have a good sleep, eat healthy, don't skip meals, don't be too anxious. Okay, we're all here praying that you get amazing ranks, and we're trying our level best to provide you with all the support you need. In case of any doubts, you can always, drop a mail. We are on Instagram and YouTube and Facebook. You can always drop your queries and anything or any doubt, we are here for you. All right, students? So take care and keep studying.